Alright, so in the last video we got through the first, I guess three pages. The first 3 pages of autonomic drugs, which pretty much sets up for the rest of the few pages, right? So there's a lot that happened in the first 3 pages, and this page especially, the G protein linked second messengers, were really important, right? So on the first page we saw there's 2 types of receptors for acetylcholine. There's the nicotinic acetylcholine receptors, which are ligand gated with sodium and potassium, and then the muscarinic acetylcholine receptors, which are G protein coupled, and those are the ones with second messengers on the next page. We went through this entire diagram. We saw how in the parasympathetic we just have muscarinic receptors in the very end that respond to acetylcholine and work with rest and digest related stuff. Whereas in the sympathetic nervous system, we only have muscarinic for sweat glands. Everywhere else, we use norepinephrine, epinephrine, or over here, dopamine, for alpha, beta, or dopamine receptors, right? The somatic ones are also acetylcholine all the way to the end, but here, this was a nicotinic M receptor, right? So we talked about all of that. We went through the various receptors over here for the G protein linked second messengers. All of these guys are guys that respond to epinephrine or epinephrine over here, alpha 1 to beta 3. All the M1, M2, M3 parasympathetic stuff is for acetylcholine. This is dopamine, histamine, vasopressin. We went through that. We talked about how to memorize this, how to remember this because it shows up on questions. Talked about this page, and now we're finally here getting ready to get started with the various medications. So the first set of drugs we see are cholinomimetic agents. So they are mimetic, which means they mimic acetylcholine, right? So they're going to be working on all your M1, M2, and M3 receptors. That's what the acetylcholine stuff was. So you come back to here, all cholinomimetic drugs are going to work on these guys and do these things, right? Whereas if you have drugs that block this, then you're going to block all of this stuff. So mainly speaking, we're looking at the things that are happening in M3, right? Because that's what the most things that happen are all M3 related, and all of this will be upregulated if you're using something that causes acetylcholine activity. So I'm going to make a little image of that just so we can keep looking at it when we need to go back. So now right here, all your cholinomimetic agents, there's 2 types. There's direct agents, which are direct agonists, or you have indirect agonists, which are anticholinesterases. Right? So what anticholinesterases do is they kill the acetylcholinesterase. Right? They stop acetylcholinesterase activity so that you do not delete your own acetylcholine. Right? Because acetylcholinesterases, what they do is they destroy acetylcholine in this junction right here. Right? So you see anticholinesterase. You could use an acetylcholinesterase inhibitor, or you could use drugs that are direct agonists of the acetylcholine receptor. So direct agonists, we just have 4 medications we need to know, and for the most part they all have chol in it. At least the first 3 do, and the last one is just pilocarpine. It's the only one that doesn't have chol in it, but the rest do. So the rest have the chol of acetylcholine. So you have betanicol, carbachol, and methacholine. Betanicol is really easy to remember just because of this sentence right here, right? Bethany, call me to activate your bladder. Right, so we just saw in the screenshot that I was making earlier, increased exocrine gland secretion, increased gut peristalsis, increased bladder contraction, cause bronchoconstriction, increased pupillary sphincter muscle contraction, so that's meiosis, so the constriction of your pupils, ciliary muscle contraction for accommodation, and increased insulin release as well as NO release. So here we're seeing that, right? Activate your bladder. Betanicol activates bladder smooth muscle and is resistant to acetylcholinesterases. No nicotinic activity though. So generally speaking, you really want to just think of betanicol for activating bladder, and you would use it in patients who have urinary retention, right? Because M3 is responsible for gut peristalsis and bladder contraction, amongst the many other things we saw in that image I just showed. So that's happening with betanicol. Carbachol is also really easy to remember, not just because of the col, but the carbo part with this statement, right? It's a carbon copy of acetylcholine. So it's pretty much just like acetylcholine. And in addition to that, it's also resistant to acetylcholinesterases. And that's a good thing. You want these guys to be resistant to acetylcholinesterases because if you're giving these medications to anybody, you're probably giving it to them to cause an acetylcholine-related effect. So if it gets degraded by the acetylcholinesterase, the effect is going to be weaker, right? So you have carbachol right here. Carbachol is for the pupillary stuff, right? So it constricts pupil and relieves intraocular pressure and open-angle glaucoma. Because M3 does that. As we just saw, it constricts the pupil and causes miosis. Methacholine stimulates muscarinic receptors in the airway when it's inhaled, right? This is used in the methacholine asthma challenge, right? The challenge test for diagnosis of asthma. M3 is supposed to cause bronchoconstriction. Asthmatics would be sensitive, and the test would give the diagnosis of asthma, right? So when an asthmatic patient inhales methacholine, they start having a very mini asthma attack, which, it's a pretty short-acting inhalation, so it stops. It doesn't cause full-blown asthma, but they will have trouble breathing, and once this stops having that effect on them, you can tell them, all right, you're definitely diagnosed with asthma, so here's what we'll do with you, and then you put them on medications. The last one is pilocarpine, which you can always remember as cry, drool, and sweat on your pillow, right? So you can call it pilocarpine. Contracts the ciliary muscle of the eye, pupillary sphincter, and is also resistant to acetylcholinesterase, right? Just like carbachol, pilocarpine is also great for eye-related stuff, but not just for the eye, right? It's also the sweat. So potent stimulator of sweat, tears, and saliva, open-angled and closed-angled glaucoma, which means this is great because there are many medications you can't give in closed-angle, some medications you can't give in open, and it also helps with people who have xerostomia, such as those in Sjogren's syndrome, right? And remember, in Sjogren's syndrome, you have no exocrine activity. They don't have any glands whatsoever for the most part, so they don't really sweat or anything. And remember, with M3, we saw increased exocrine gland secretions, everything. Right, so pilocarpine is for this first statement, increasing all exocrine gland secretions. So that takes care of that. Then you have your indirect agonists. Now, indirect agonists, a lot of these should seem pretty familiar too. I mean, the first three are very familiar from neurology. Donepezil, rivastigmine, galantamine. These are medications you give to Alzheimer's patients. They're actually first line for Alzheimer's disease. They increase the amount of acetylcholine that's endogenously present because they simply stop acetylcholinesterase from killing the acetylcholine you're making. Right, so that's those three guys. Edrophonium also increases acetylcholine, and historically it used to be used to diagnose myasthenia gravis. Now you diagnose myasthenia gravis by looking for antibodies to the acetylcholine receptor. Right? Once you find antibodies to the acetylcholine receptor, you know the person has myasthenia gravis. But edrophonium still does show up in questions on step 1 or NBME, where they'll mention something like this happened and it was used to diagnose myasthenia gravis. But it doesn't really happen anymore. Neostigmine, physostigmine, and pyridostigmine. Right? All of these also end in stigmine, just like rivastigmine up here did. Right? So what does neostigmine do? Neostigmine, this statement here works for me pretty well. Right? So neo-CNS, no CNS. It doesn't have any CNS penetration, so because it's a quaternary amine, and neostigmine is actually used post-operative, right, to treat post-operative urinary retention. It's a pretty common thing that happens. Post-operative and neurogenic ileus and urinary retention. Very good medication for all of that. You can use it for myasthenia gravis. You can also use it to reverse neuromuscular junction blockade post-operatively. All right, so a lot of questions show a stem where some kind of operation is happening, stuff like that is taking place, and then the patient starts having some kind of symptoms. You have to figure out if neostigmine would be the solution to the symptoms they're having. Physostigmine increases acetylcholine also. Well, they all obviously increase acetylcholine. Physostigmine, though, this guy can freely cross the blood-brain barrier because it's a tertiary amine. So now, because it can cross the blood-brain barrier, it's an antidote for anticholinergic toxicity. Right? Anyone who has too much anticholinergic medication or something, you can use physostigmine. So physostigmine fixes atropine overdose. Remember, atropine overdose is basically a sign of excess acetylcholine, right? Too much anticholinergic activity. Not excess acetylcholine, excess anti-acetylcholine, so anticholinergic activity. When we get to atropine, we're going to see all the things that atropine does, and you're going to relate that to all the things that M3 is supposed to be able to do, right? And you're going to see what's happening there. And physostigmine is the solution. Physostigmine increases the amount of acetylcholine that's available, and you fix all the issues atropine overdose causes. The last one is pyridostigmine, which I always remembered would get rid of myasthenia gravis. Pyridostigmine gets rid of myasthenia gravis. It increases muscle strength and is used with glycopyrrolate, hyoscyamine, or propanthamine to control pyridostigmine side effects. Right. So these three medications used to be mentioned in another page before. Right here you see glycopyrrolate, hyoscyamine, and dicyclomine. Right, because there's a lot of side effects that pyridostigmine can have, which are pretty much normal effects of M3 upregulation, I suppose. And you don't want those things to happen because all you're really trying to do is fix myasthenia gravis. Right, and it's also a quaternary amine. It cannot enter the CNS. So the only one that can is really physostigmine. It freely crosses the blood-brain barrier. Pyridostigmine gets rid of myasthenia gravis, and you give it with one of these other medications to help with the pyridostigmine side effects. The last thing here on this page are your anticholinesterase poisoning. Right, so this is different from when they mention anticholinergic toxicity, right? Anticholinergic toxicity is toxicity where you don't have any acetylcholine, right? Anticholinergic toxicity here, this is anticholinesterase poisoning, which means that you don't have any cholinesterase, so you're going to have too much acetylcholine. And in anticholinesterase poisoning, that's what you're going to see. You're going to see a patient who's fully exhibiting all of those symptoms that M3 causes, right? Look at this guy, right? So this is an image of a average patient who might be undergoing organophosphate poisoning, and an organophosphate is actually something that irreversibly inhibits acetylcholinesterase. So if you stop acetylcholinesterase activity, you're going to end up having too much acetylcholine. So you're going to have increased exocrine gland secretions, which means lacrimation from the eyes, sweating, right, salivation from his mouth, even vomiting, and gastric acid, right? That's the vomiting part. More gut peristalsis, so he's going to have the diarrhea. Increased bladder contraction, so he's also going to have excess urination. Bronchoconstriction, which is going to make it a little difficult for him to breathe correctly. Increased pupillary sphincter contraction, so his pupils are going to be pinpoint pupils, meiosis. Ciliary muscle contraction, which will make it difficult for him to see stuff correctly. And endothelium-mediated vasodilation, which might lead to hypotension and reflex bradycardia and stuff like that, right? There's also bradycardia because of M2, right? M2 is also, it was one of your GI, it was inhibitory, and it also caused cardiac effects. If we go back to right here, right, M2 is a GI, it decreases heart rate and contractility, right? So we're going to be seeing excess acetylcholine effects in people who have organophosphate poisoning. Organophosphates inhibit acetylcholinesterase, so you end up having too much acetylcholine, and then you see the patient go crazy with all those acetylcholine M1, M2, M3 effects. And keep in mind, everything we talked about on this page has to do with parasympathetic stuff, like peeing, right, going to the bathroom, for any reason whatsoever, really. So peeing, pooping, crying, right, all of these things that are parasympathetic, they are now sympathetic activities. What else is there? Oh, and sweating, right? But sweating not because of exercise, sweating really because you're just really hot or something. All of those M3 activities, everything from that page, right? Everything from that little snippet right here. All of these things, right? Of course, salivary and gastric acid and your gut peristalsis, because eating is parasympathetic as well, right? So whenever you see a question where something parasympathetic is not working, you want to think that the person doesn't have enough acetylcholine. And if something parasympathetic is working too well and they have too much of it, then you want to think they have too much acetylcholine and you need to block that activity. So in these people, where these questions are usually, and still thankfully usually, about farmers, right? It's going to be poisoning usually seen in some kind of farmer. Organophosphate poisoning just happens, right? And then they're going to present with all these things. Muscarinic effects are going to include diarrhea, urination, meiosis, bronchospasm because of the bronchoconstriction, bradycardia because of M2, emesis, lacrimation, sweating, salivation. You don't even need this dumbbells thing, right? It's really just understanding all the parasympathetic things that can happen and all the things that your M3 receptor really does. This stuff, the muscarinic effects, will be reversed by simply giving the patient atropine, which is a competitive inhibitor of acetylcholine activity. Right? Atropine also crosses the blood-brain barrier and relieves CNS symptoms, so that's going to be perfect. So you take care of all the muscarinic stuff. Then you have nicotinic effects also, because remember, from our first page, right, you have nicotinic effects of acetylcholine up here. Right, all the nicotinic effects of acetylcholine. This is muscarinic, but all the nicotinic effects of stuff right here, that's going to go activate norepinephrine, dopamine, norepinephrine, epinephrine. You need to block that stuff too. Right, so we block the muscarinic effects. Neuromuscular blockade, mechanism similar to succinylcholine. Right, having too much acetylcholine can lead to neuromuscular blockade, and to reverse that, you have to use pralidoxime, which regenerates acetylcholinesterase if you give it early enough. Pralidoxime does not readily cross the blood-brain barrier because it is a quaternary amine. So a lot of questions will often ask you, what else do you need to give this patient immediately to help them? You need to give them pralidoxime. That's the answer for that question. The last thing are your CNS effects, which will be taken care of by atropine because it does get to the CNS. But the CNS effects are going to be respiratory depression, lethargy, seizures, and coma. And that is coming from the M1 stuff. Remember, M1 mediates higher cognitive function. Right? So seeing them in coma and stuff like that can be due to M1 for the most part. So that's everything with anticholinesterase poisoning from organophosphates in a farmer. Give them atropine, give them pralidoxime. And we're going to see some questions on how to do that too. Now the next thing are your muscarinic antagonists. We already spoke about one, atropine, right? Muscarinic antagonists. So muscarinic, I put a snippet from the beginning right here again. Right? You can see muscarinic antagonists are basically antagonizing these two receptors, the two green M receptors. So if we're antagonizing that, we're going to stop all of this from happening, right? So we're going to stop all the parasympathetic stuff, and we're going to stop only one sympathetic stuff, which is sweating, right? But we're going to stop all the parasympathetic stuff. So basically, this is going to lead to no rest and digest, right? You're not going to have any rest and digestion. So atropine, homoatropine, and tropicamide, these three medications are related to the eye. They actually cause mydriasis and cycloplegia, right? So the opposite of doing meiosis and accommodation. Cycloplegia is paralysis of the ciliary muscle of the eye, resulting in a loss of accommodation. Because of the paralysis of the ciliary muscle, the curvature of the lens can no longer be adjusted to focus on nearby objects. And that's what these medications can help with, or lead to. Benztropine and trihexyphenidyl are for the CNS, and they're mainly just used for Parkinson's disease. Right? You can use it for acute dystonia. Glycopyrrolate, hyoscyamine, and dicyclomine we saw earlier need to be given with pyridostigmine to take care of pyridostigmine side effects. Glycopyrrolate, all three of them are related to GI, right? But glycopyrrolate also has a respiratory effect. So what do? Glycopyrrolate you can give parenterally or orally. Parenterally is for preoperative use to reduce airway secretions, right? Because remember, you're blocking the M3 activity. M3 upregulates secretions. If you give glycopyrrolate and you block M3, you're not going to have any secretions, right? So reduce airway secretions. And if you give it orally, it's for drooling and peptic ulcers, right? So that's what that helps with. Hyoscyamine and dicyclomine are for antispasmodics for irritable bowel syndrome, IBS, all right? Ipratropium and tiotropium are going to show up again when we get to respiratory, right? They are for COPD and asthma. So you can say, I pray I can breathe soon. I changed it to, I pray that Theo can breathe soon. Theo is Spanish for uncle, right? So I pray that Theo can breathe soon, and that'll remind you of both ipratropium and tiotropium. So you learned the Spanish word, right? Theo is Spanish for uncle. Oxybutynin is actually a very important high-yield medication, but so are the other two because they can all be related to the other high-yield topic I spoke about in the last video a little bit, which is your urinary incontinence, right? So they reduce bladder spasms and urge urinary incontinence, overactive bladder. So if you have a question about urged urinary incontinence, where they just really need to go pee, they feel like they need to go pee, you can give oxybutynin, which is a muscarinic antagonist, so it'll antagonize that M3 bladder contraction, and they won't have that urge, right? They won't have that overactive bladder anymore. So the sympathetic system will relax the detrusor muscle while the parasympathetic muscle activates it to cause bladder contraction, via M3. If we antagonize the muscarinic receptors, then we reduce bladder spasms and help relax the bladder so that it can just fill and you don't have this urge to pee. The last medication here is scopolamine, which is used for motion sickness. Right, so it's a CNS one, pretty common. Atropine, which we just talked about on the last page, is your treatment for organophosphate poisoning, right? So organophosphate poisoning, remember, it meant that you got rid of all your acetylcholinesterase, so you have too much acetylcholine, and you're going to have too much M3, M2, M1 activity. So you're sweating, and everything is just coming out. Urinating, pooping, salivating, crying, and sweating, right? Super, super liquidy. Atropine is a muscarinic antagonist. It does the opposite of all of that, right? You're going to stop all the sweating, stop all the urinating, stop all the pooping. So normally, right, it can be used in these organ systems for these actions. However, something bad can happen if you have atropine overdose. And that's what everybody remembers as the hot as a hair, because you're not sweating anymore. Dry as a bone, again, because you're not sweating anymore. Red as a beet. Blind as a bat, because remember, that medication, the muscarinic receptors and acetylcholine, they caused meiosis, which, you're not going to be super blind by meiosis. But if you have mydriasis, which is what you're going to get now, mydriasis makes your pupils really dilate, and so much light is coming in that you can't see anything. So you get blind as a bat, mad as a hatter, and full as a flask. Full as a flask because you're going to have urinary retention. Remember, M3 causes bladder contraction, so you can actually go pee. It's the parasympathetic stuff. Now you're stopping all the parasympathetic stuff. So you want to imagine not being able to do all the parasympathetic rest and digest things. And if you can't do your rest and digest things, you're going to be super pissed off and hot and all of these things that you have here. And you won't rest, and you're not going to digest anything. You're not going to pee either. So that's what's happening with this patient. You have a really high heart rate, which is actually extremely critical because, a lot of students I've met have trouble making that differentiation between atropine overdose and organophosphate poisoning, even though they're complete opposites, right? And the reason is because a lot of questions tend to seem very similar, but the elevated heart rate is really critical, right? Almost all questions tell you something like this right here, right? This little box: temperature, blood pressure, pulse, respiratory rate. You see how this person's pulse is 110? This must be a question about atropine overdose. Because normally, if you have a lot of acetylcholine, that means that you have acetylcholinesterase poisoning, and you have a lot of acetylcholine, you must have been organophosphate poisoned. If you have a lot of acetylcholine, that's going to go to M2 and decrease your heart rate, right? Because M2, all the muscarinic stuff, it's parasympathetic, it's for resting. Resting has a low heart rate. Atropine does the opposite of muscarinic stuff, so you're not going to have any rest and digest, so you're going to have an extremely high heart rate. And that one fact alone really helps figure out, whether or not a person has atropine overdose. Other than that, of course, elevated body temperature, dry mouth, dry flushed skin, everything's dry. It's almost like the person has Sjogren's syndrome, right? Can also cause acute angle closure glaucoma in the elderly because the mydriasis, all that dilation of the pupils, and urinary excretion in men, urinary retention, especially in men with BPH. And you can see hyperthermia in infants because infants also need to sweat. So now look at all these questions about atropine. So this one right here, 16-year-old boy is brought to the emergency department due to progressive confusion and agitation for the past several hours. His friends report that he started to act bizarre after chewing some plant seeds. They state that he said bugs were crawling on his skin and that he was talking to people who were not there. He himself reports blurred vision. He also frequently interrupts the emergency department staff asking for water. He is uncooperative with the exam, but his mucous membranes are dry and his skin is warm and flushed. His presentation is most similar to an overdose with which drug? Obviously, this looks like atropine overdose. And the seeds or whatever that he was chewing on, so that's this stuff, right? Jimson weed, also known as datura, leads to Gardner's pupil, right? Mydriasis due to plant alkaloids. So you're not supposed to eat Jimson weed, but if you do, or if you just happen to be trying it or chewing it or something, it's going to present very much like atropine overdose because it just does the same kind of shit. Right, so that's what happened to that 16-year-old boy who was out there doing what? Started bizarre, chewing some plant seeds, right? And that's never a good idea. You don't want to chew plant seeds you don't know. Then here, atropine overdose questions are quite high yield. Questions will often have extra information and try to be confusing. And these are more atropine overdose questions from UWorld. So let's pay attention and see what's up with them. Because this is pretty much like these 4 questions are generally going to encompass every possible way you can get tested on atropine overdose or use of atropine. This one here, 78-year-old. So we went from 16 to 78. This is a 78-year-old man who was found to have a perihilar mass on screening CT scan. The patient's medical history is remarkable for COPD, for which he takes albuterol inhalers as needed. He has smoked a pack of cigarettes daily for the last 50 years, but does not drink or use drugs. The patient is admitted for bronchoscopy and is pre-medicated with intramuscular atropine and becomes acutely restless, disoriented, and combative. So he was given atropine, alright. Temperature is 100 F, blood pressure is 116, pulse is 110, and respiratory rate is 15. Oxygen saturation is 99%, and physical exam reveals dilated pupils, non-reactive to light. So we're already seeing everything that we're supposed to see, right? We got the high pulse, we got dilated pupils, so you don't have meiosis, you're blocking meiosis, you have mydriasis, and ECG shows sinus tachycardia, which is the high heart rate, which we already figured out, pulse is 110. What agent will reverse all of his signs and symptoms? And the answer here was to give physostigmine, right? When you have atropine overdose, you need to give something that's going to increase the amount of acetylcholine you have. So if we go back to physostigmine, right, that was this one in the middle, right? The one that freely crosses the blood-brain barrier so it can reach the CNS and reverse CNS symptoms also. And it is the antidote for atropine toxicity, right? Atropine overdose. Physostigmine fixes atropine overdose. Pyridostigmine gets rid of myasthenia gravis. And physostigmine is the only one, by the way. It is the only one that the book teaches you, at least. That's a tertiary amine, so it can go to the CNS. Neostigmine and pyridostigmine do not have CNS penetration. They're both quaternary amines. Right, so you just give this guy physostigmine. With atropine overdose, give him physostigmine. He's going to be okay. This one again, 50-year-old man brought to the emergency department after developing blurred vision and confusion. Earlier today, he was clearing and burning foliage and weeds on his property. His medical history is insignificant, and he does not take any medications or use drugs. Temperature is 102 Fahrenheit, blood pressure is 110, pulse is 120. So again, with the high heart rate, right? Respiratory rate is 16. He is disoriented to time, place, and person. Physical exam shows flushed skin, dry oral mucosa, both pupils are dilated, non-reactive to light or accommodation, and bowel sounds are decreased because you can't do rest and digest. The reason you are unable to do your resting and digesting is because you have acetylcholine blockade, or you have a lack of acetylcholine. And that's what atropine is, right? Atropine is a muscarinic antagonist. So you have acetylcholine blockade. You're not able to do all your acetylcholine stuff. So what drug can reverse the conditions? Physostigmine once again. Really straightforward. This patient most likely developed anticholinergic toxicity from encountering Jimson weed while working in his yard. Done. Last question here. 52-year-old man comes to the office for an annual preventive visit. He has a history of seasonal allergies and has recently started taking a medication that has improved his runny nose, sneezing, and watery eyes. Medical history is remarkable for diet-controlled type 2 diabetes and eczema. He is not on any other medications. He does not use tobacco, alcohol, or drugs. Exam shows a well-appearing man with flushed cheeks and dilated pupils. Right, so this is flushed cheeks, so red as a beet, dilated pupils, so blind as a bat. His physical exam findings are best explained by what mechanism? And his physical exam findings of runny nose, a medication that improved his runny nose and stuff, so it stopped having runny nose and all that, right? Stopped sneezing, stopped having watery eyes, and then now also has flushed cheeks and dilated pupils. All of that is due to antagonism of muscarinic receptors. That's how else are you going to stop all that exocrine function? Anticholinergic toxicity is the anticholinergic toxicity is the problem here. He is most likely taking a first-generation antihistamine like diphenhydramine, which acts as an antagonist to multiple receptors, including muscarinic acetylcholine receptors. His flushing is likely due to compensate. His flushing is likely to compensate for his excess body heat due to decreased sweating, and the pupillary dilation is due to inhibition of his iris sphincter. This drug is commonly described as an H1 antagonist, and H1 receptors mediate vascular permeability and bronchoconstriction, as well as alertness in the CNS. Right, so a lot of different ways to present atropine overdose, and a lot of different scenarios where you can have anticholinergic toxicity. Right, anticholinergic. There's no acetylcholine available. For some reason, there's just no acetylcholine. So the only way to fix it is to give stuff that acts like or increases acetylcholine. And physostigmine is the mainstay of treatment because that's the one that can go to the CNS. Alright, so that takes care of that. Now we're looking at sympathomimetics. So now we're looking at the alpha 1, alpha 2, beta 1, beta 2, and beta 3, as well as the dopamine receptors. And all of these are receptors that are affected by norepinephrine, epinephrine, and of course for dopamine. Norepinephrine and epinephrine are going to be really high yield in your step 1. You have to know what receptors they prefer and what they cause. Right now, as sympathomimetics, they're going to cause more sympathetic activity, which is your fight or flight activity. So first thing we see here, obviously very high yield stuff, albuterol, right? Albuterol, salmeterol, and terbutaline. These are, you've seen albuterol over and over. This is generally used for asthma. So albuterol is for acute asthma COPD. Salmeterol is for serial or long-term asthma COPD. Terbutaline is for acute bronchospasm in asthma and for tocolysis, right? In uterine contractions and stuff. That's what tocolysis is related to. So generally speaking, these guys like to act on beta 2 to cause bronchodilation. Right, and they can also act on beta 1 to increase contractility, but not so much. The mainstay or the receptor they really prefer is beta 2. And then by causing bronchodilation, it allows for these people to obviously breathe. Dobutamine is pretty big. This medication shows up a lot. It's actually not in cardiovascular pharmacology. They don't mention this medication again in first aid. They only mention it here, and it's actually a beta 1 agonist. So by being a beta 1 agonist, it's able to increase contractility. You can give this to patients who have heart failure, cardiogenic shock, or cardiac stress testing, and it is actually used in cardiac stress testing, dobutamine. Right? So you can see it has a preference though for many other receptors too. It also has a preference for beta 2 as well as alpha, but the main effect it has is primarily on beta 1. Dopamine can actually act on dopamine 1 and dopamine 2, D1 and D2 receptors, but so of course it acts on D1 and D2 receptors, but it can also actually have effects on beta and alpha. But the mainstay is that it's going to have effects on D1 and D2, and that ends up being really helpful for, of course, the CNS stuff and Parkinson and all that, but mainly renal effects. You can give dopamine for unstable bradycardia, heart failure, and shock. Inotropic and chronotropic effects at lower doses due to beta effects. Vasoconstriction at high doses due to alpha effects. And this difference in what it does based off of dosage can be tested. Right? So low dose dopamine is going to cause beta effects. So that's going to be more contraction, right, of the heart, beta 1 effects mainly. But at higher effects, it can cause alpha 1 effects, and alpha 1 causes vasoconstriction. So that's what they're talking about here. And then I wrote, dopamine is excellent for shock because it raises the blood pressure without reducing the renal vascular flow, since D1 receptors relax renal vascular smooth muscle and preserve kidney perfusion, whereas norepinephrine would decrease renal perfusion. So dopamine would be preferred in a patient with low blood pressure and no urine production in the past 24 hours. Phenol-dopam is best for blood pressure, which is the next one right here. Right, so these are your two medications that are dopamine related, but they do more than just what we generally think of when we think of dopamine. Right, so we're seeing dopamine right here for shock, heart failure, and unstable bradycardia. Phenol-dopam acts on D1 receptors. You can give it for postoperative hypertension as well as hypertensive crisis. It's a vasodilator. right? So coronary, peripheral, renal, and splanchnic. So it increases it increases blood flow everywhere, including the renal stuff, and that's great because for hypertension, if you have more renal perfusion, you promote natriuresis. If you have more natriuresis, you lose sodium in your urine, and that also helps with hypertension. Right? So it can actually help so much that it can lead to hypotension and tachycardia. So that's why, it's there in the book, but it really doesn't happen per se. You're going to monitor how much you're giving to your patients, and you're going to be careful with it. So there's that. Epinephrine, they finally mentioned. Epinephrine is mentioned there. Norepinephrine's over here. I wish they were right on top of each other or something, but they're far away. So let me just drag this down to here. Okay. So epinephrine works mainly on beta 2 and beta 1 and then alpha 1. So initially, when you give someone epinephrine, it's going to act on beta 2 receptors, which is great because as a beta 2 agonist, it'll help people breathe, right? Because it's for the lungs. Then it'll act on beta 1 receptors, so that's going to increase contractility, and then it might act on alpha 1 receptors, which can lead to hypertension. So they tell you the alpha effects predominate at high doses. So if you give a very high dose of epinephrine, it's mainly going to work on alpha 1 receptors. Significantly stronger effect at beta 2 than norepinephrine. Now we look at norepinephrine. Norepinephrine is the opposite. You see this? Starts at alpha 1, then alpha 2, then maybe beta 1. They don't even write beta 2 here. You can give someone norepinephrine if they have hypotension, because by being an alpha 1 agonist, it'll cause vasoconstriction, which will bring their blood pressure up. So that's how they're completely opposites, right? They don't work on the same receptors. They work on opposite receptors. They work on alpha 1. Norepinephrine works on alpha 1 and then alpha 2. And remember, alpha 2 was your GI thing, as inhibitory. It brings down all the other receptors, right? It brings down sympathetic activity. So everything is going to go down. You're literally going to start going into parasympathetic mode and start resting, right? So that's the big difference between epinephrine and norepinephrine in terms of receptors. And you have to know that because that's one, that's very important as a doctor. You obviously need to know that. And two, because it's going to get tested. So that's why we're all here. The next medication, isoproterenol. Iso as a prefix always means equal or the same. So basically it has the same effect on beta 1 and beta 2. So it's going to cause both increased contractility as well as increased breathing, right? More bronchodilation. Electrophysiologic evaluation of tachyarrhythmias can worsen ischemia, has negligible alpha effect. Right? So this is the only time you really see isoproterenol though. If someone's trying to figure out what's causing tachyarrhythmias, you give isoproterenol and then you do an electrophysiologic evaluation. Midodrine is an alpha 1 agonist. So being an alpha 1 agonist is going to cause hypertension. So autonomic insufficiency and postural hypotension may exacerbate supine hypertension. Right? So it can help with postural hypotension, which is when you stand up, you end up feeling a little lightheaded, but it can worsen the blood pressure a person has when they're sleeping, right? The supine hypertension. So you want to give it to someone in a very careful manner. Mirabegron is actually a really cool medication. This is the one that works on beta 3 receptors. And you give this in urge incontinence or overactive bladder. So I feel like this is definitely going to be a medication that might be on step 1 of many of you guys that are taking it soon, because this medication is relatively new. It's not really been in first aid for a long time either. And on top of that, anything about urge incontinence or urinary incontinence in general is pretty high yield. So they're really starting to, make questions a little harder nowadays. Rather than just asking you what does it mean to have urinary incontinence of different types, they want you to be able to deal with it after diagnosing it. So once you diagnose someone has urge incontinence, you need to know that you can give them mirabegron to help, right? Because way in the beginning we saw that beta 3 receptors, which is a pretty relatively new thing, is also, all the betas are GS, so they all stimulate something, but the only real thing beta 3 stimulates is bladder relaxation, right? So someone who has an overactive bladder that keeps contracting and keeps making them feel like they need to pee, you can give them a beta 3 agonist and cause bladder relaxation. So that's one medication I would definitely ask that you guys memorize, because you don't wanna mess that up. It's not worth the trouble to go through. Now, where are we now? So that's, and then the last one, phenylephrine. Phenylephrine is a medication a lot of times they'll use in questions just to really confuse you, rather than asking about norepinephrine or epinephrine directly. I just think of phenylephrine just like norepinephrine, right? So you could see pretty much the same exact thing in terms of receptor preference. So it also causes hypotension, right? Because it also causes hypertension because alpha 1 is vasoconstriction. So you could use it for hypotension, just like you could use norepinephrine. It also has ocular procedure help, right? You can give it to people with ocular issues, and you can give it for ischemic priapism, which is one thing that I have seen phenylephrine show up for. Ischemic priapism. Ischemic priapism is basically pain in the penis due to ischemic reasons, and that's something that happens to patients who have sickle cell. Right, priapism is definitely an issue that can happen to sickle cell patients as well as many other people. How to study pharmacy? I mean, it's, with pharmacology, it's really like an experience thing. You understand what medications do the more you use them. I don't want everyone to be taking anything, but if you were prescribing medications, you definitely start getting really good at it. If there was some kind of video game out there where you kept having random patients coming and then you have to start giving them medications, you'd be able to go ahead and get better at that, right? That's one thing you'd be able to do. Other than that, in terms of memorizing medications, it's just a time thing. There's no real way to get good at Now, if you're talking about getting good at the other pharmacology stuff that we covered in the last few days, such as pharmacokinetics and dynamics, that you can get good at in like a good 2 to 3 days easily and master KM and Vmax. But to remember medications, it's just application. The more times you read it, the more times you think about it, the more times you try to think of real patients you might have worked with and what medication could have helped them, that's when it starts becoming really serious, right? Because you want to be able to relate it to something applicable rather than just sitting there and memorizing medication names and what do they do. Medication name, what does it do? Because eventually that's going to just become really, really boring and there's no helping it once it becomes boring. You can't do anything about it. Right, so as we keep going, for example, cardiovascular, endocrine, etc., we're going to see so many medications in every single section. And there's really no easy way to know all the medications. The only thing you can do is really have a good understanding of who you would give these medications to. Maybe, you have to think of something you could do. Like, one thing I did was that I would think of people I knew, either patients I met in random rotations or people that I know in terms of friends or family, and I would think of what medications I would give to these people based off of what issues I know that they have, just by looking at them or by hearing from what medications they already take. And that kind of imagining and that kind of playing around in your mind about medications can really make this a more personal thing. Other than that, it's mostly just drilling it in. With time, you're supposed to be able to know all the medications and how they work, what they do, their mechanism of action, side effects, etc. With experience, it becomes even easier. But experience comes after working, and you can't even start working if you don't pass step 1, so it's a really bad circle. And to answer Mohammed, I'm looking to go into internal medicine. That's my number one goal. I want to go into internal medicine and eventually start practicing cardiology. So that's my long-term goal for now. Alright, so that's phenylephrine. Right here I wrote, compared to dopamine, norepinephrine can significantly decrease renal perfusion, especially if given in conjunction with NSAIDs. Beta 1 increases renin release and alpha 1 causes vasoconstriction, so there are no vasodilatory effects. Right, so compared to dopamine, norepinephrine significantly decrease renal perfusion. Oh, right. We made that comparison already, right? Giving either norepinephrine or dopamine for someone who has shock, what's a better idea? Well, you want to give dopamine because you want to be able to continue your renal perfusion. If you give norepinephrine, you're not going to cause renal perfusion, and that's going to be pretty problematic. The last thing here are your indirect sympathomimetics. So these are the medications, just like you had indirect acetylcholine by just blocking acetylcholinesterase. Here, you block norepinephrine and epinephrine reuptake or destruction. Right, so amphetamine is an indirect general agonist, reuptake inhibitor, also releases stored catecholamines. So it does two things. Right, so it just really causes you to have a lot of epinephrine and norepinephrine in your system, and you could use it for patients with narcolepsy, obesity, or ADHD. And it's pretty common. I've seen people use it to have better focus even. I've definitely seen people who used it for obesity, and it does eventually start helping. It's just amphetamines have too many side effects. It's not worth it. You're better off doing something else than trying an amphetamine. Cocaine is an indirect general agonist also and a reuptake inhibitor. So again, this also causes vasoconstriction and local anesthesia. Caution when giving beta blockers if cocaine intoxication is suspected. Can lead to unopposed alpha-1 activation, which causes extreme hypertension and coronary vasospasm. Right? So you want to think of all of these guys, generally speaking, you want to think of them as excess alpha-1 activity, but also beta-1, beta-2, etc. activity. Right, so if you have someone with cocaine, they're going to have alpha-1, beta-1, beta-2, all of that activity. And now if you give them a beta blocker, you stop the beta activity. The beta activity was causing vasodilation. You stop vasodilation and you let alpha-1 predominate, that's going to cause a lot of hypertension because of vasoconstriction. The last one is ephedrine. This is also an indirect general agonist, and it causes release of stored catecholamines. So ephedrine is commonly used for nasal decongestion, urinary incontinence, and hypotension. So again, we have another medication for urinary incontinence, and they love these medications because when you finally go talk about urinary incontinence in just first aid itself, it doesn't have much. But in my version with my annotations, I have a bunch of notes when we finally get to urinary incontinence. I should put a tab for that. I don't remember where it is. But urinary incontinence, I have a lot of notes there, and I also mentioned all the medications you would use for the various urinary issues. Here we have a question from Amboss. An investigator is studying physiologic changes in the autonomic nervous system in response to different stimuli. 40 micrograms of epinephrine is infused in a healthy volunteer over a period of 5 minutes, and phenoxybenzamine is subsequently administered. Which of the following effect is most likely to be observed in this volunteer? Right, so you gave a lot of epinephrine, and we already know epinephrine predominates beta activity. Then you give phenoxybenzamine. We haven't looked at phenoxybenzamine yet, but it's coming up. Phenoxybenzamine is an alpha blocker, right? We use it for pheochromocytoma. So epinephrine is going to upregulate beta and then some alpha stuff, but then you also gave a alpha blocker, so you're really just going to have beta effects. And in your answer choices, you were just supposed to pick anything that was a beta effect. And increased insulin secretion was the answer choice they went with, which a lot of students don't tend to remember, right? Because which one? You see, alpha-2 decreases insulin release, whereas beta-2 increases insulin release. So all you really need to remember is beta-2 increases insulin release. That's all you really need to remember, because remember, alpha-2 decreases everything. It decreases the activity of all four of these other receptors, right? It decreases sympathetic outflow. So just remember beta-2 increases insulin release, and that was the only answer choice you could pick from all those choices. But if you forgot what insulin release had to do with any of these receptors, you would not recall. Right? So at this moderate dose, epinephrine is a non-selective adrenergic agonist. Phenoxybenzamine is an irreversible alpha antagonist. Insulin secretion is inhibited by alpha-2 receptor agonism and stimulated by beta-2 receptor agonism on pancreatic cells. The alpha-adrenergic effects of epinephrine are blocked by phenoxybenzamine, which blocks both alpha-1 and alpha-2 receptors irreversibly. As a result, the beta-adrenergic effects of epinephrine on the pancreas would predominate, leading to an increase in insulin secretion. And the other answer choices didn't make any sense. They were not related to beta receptors at all. So there was no sympathetic stuff. Remember, all the alpha-1, beta-1, beta-2, beta-3, they're for sympathetic activity, fight or flight activity. Alright, so that's that. Now, from here on, it gets a little more difficult. This table I definitely want to spend some good time with and make sure that I can explain how all of this stuff works. And in the next video, I'll just finish this up. The rest of it is pretty straightforward and simple. So I'm going to stop here. We'll come back in the next video later tomorrow probably, and then I'll go into the rest of this.